webinar series. Thank you so much for being here with us. Today's webinar is called Family Partnership in Children's Services. This webinar is very important as it has been found to improve satisfaction with services when using family partners and also helping with engaging families into care, which is really important. Most of my work here personally is with CTAC is with the 4Rs and 2Ss for Strengthening Families program. An integral part of this work is collaboration with families, family partners and clinicians. The recommended model is that both a clinician and a family partner or parent advocate actually co-facilitate the group. So I'm often asked how this relationship really works and how clinics can get a family partner or how they can be utilized in their clinic setting. So that was one of the impetuses behind this webinar. So we're really lucky to have some really amazing people with us today, amazing experts in the area, to present on their knowledge and their experience with the family partnerships in children's services. I'm going to let them introduce themselves to you in a minute, but before we begin, I just want to let you know a few things. The slides, and there's also an attachment that will be available on our website by the end of the day today. You can also feel free to chat your questions during the webinar, and we will try to answer them throughout, or we'll also have time at the end for questions and answers. The chat function is on the bottom right for those of you that are new to the WebEx system. You'll chat your question in the little box, and then you'll click Send to all panelists, and we can answer your questions at the end or throughout if we have time. As always, when you leave the webinar, we'd appreciate your feedback so that we can take it into consideration for future webinars. As I said before, we're so lucky to have our presenters today. I'm really appreciative of all their hard work and so appreciative that they're here today to share their knowledge and experience with us today. I'm going to ask them to introduce themselves now, and we'll begin. So, Dr. Mary Ackery, can you please introduce yourself?
Hi, my name is Mary Ackery, and I'm an assistant professor at NYU School of Medicine. I'm also affiliated faculty with the Ideas Center, which is a center that is aiming to improve family support amongst other initiatives.
Hi, Geraldine Burton, and I am a parent partner. I'm also with the Ideas Center, and I've been here since June, and prior to that I was at Columbia University, and I work with Dr. Kimberly Hogewood. I've worked on several research projects. What brought me into the research field was a project by the name of PEP, which is the Parent Empowerment Project, a curriculum for family advocates to train them to become family advocates. In New York City, it originated from New York City, and at that particular time in 1999-2000, there was no formalized training for parent advocates. So that was my entree into the research arena. I've been a parent partner for about 15, 16 years, and I'm glad to be on this webinar. Thank you.
Good afternoon, Maura Manning here. I'm the Director of Children's Mental Health Services and Children with Special Needs for Albany County Department for Children, Youth, and Families. And in the past, I've held the position of a Project Director for the SAMHSA grant, which really brought Albany County to the forefront of really having family-driven and youth-guided services.
Hi, I'm Joan Ruckert. I'm one of the parent partners at Albany County Children's Mental Health, and I've also helped facilitate 4 R's, 2 S's with one of our groups at the clinic. And I've been a parent partner since 2007. I was part of the SAMHSA grant originally.
Good afternoon. My name is Sandra Staggers. I'm a family partner at the Institute for Community Living. I'm also the Associate Director and Senior Advocate here, and I've been an advocate for over 12 years, and I have a 21-year-old son who has been in and out the system, and I'm here to hopefully educate and enlighten parents and also professionals about how we work together. Thanks.
Hi, everybody. I'm Ann Cuppinger. I'm the Director of Training and Credentialing at Families Together in New York State. Families Together is the statewide chapter of the Federation of Families for Children's Mental Health. And we're involved in a lot of different work with family advocates and partners. And I'm very excited about the growing involvement and partnerships between family advocates and clinicians, especially in a kind of clinic setting. So I'm looking forward to this, and thank you very much.
Thank you, everyone. Thank you so much. See, we have so many great people talking with us today. So we're going to get started with the agenda and the webinar.
Okay. So today we'd like to cover the history of family support services and provide a definition of what entails family support, and move into an overview as to initiatives in New York State with respect to family support services, and we'll provide examples of efforts in both Albany and New York City, and then talk a little bit about funding and then field any questions that you might have. Next slide. So I'm not going to go too much in detail about the history of family support services, but I certainly can answer any questions if there are specific questions about it. The growth in family support services has been concurrent with the growth in child mental health services. Before 1986, families were not, there wasn't as much attention to families of children with identified mental health problems. A system of care principle document that was released in 1986 set some early guidelines, such as a focus on the strengths of the child, the family, and the community. Since then, family support services has grown quite a bit, as you can see through the timeline. And currently, we're at a point in which certification programs are now in place across several states, and some of the services are billable under Medicaid. Family support services are typically defined as services directed at caregivers of family members, children or adults in the child health or mental health system. So they're services targeted towards the family members who have an active role in that child or adult's care. Up until recently, there really wasn't a clear consensus regarding what family support services entailed, but in 2010, we published a systematic review of 50 child mental health interventions that offered family support services, and we developed a typology of family support. And what we came up with was that there were 5 types of services that family support consisted of, and those ranged from informational support, and that's information about the child's mental health needs or treatment, instructional support, communication skills, anger management skills, emotional or affirmational support, which is support provided between the person providing family support services as well as a function of, say, a group setting in which that family member is receiving support from other individuals going through similar experiences. Instrumental support, which is really that concrete support, transportation, child care, and so forth. And advocacy support, which is of 2 types. Advocacy meaning both the person providing family support advocates for the family member, maybe at a school meeting or with mental health providers, as well as working with that family member to become empowered and an advocate for their own family. Peer-delivered family support services is an innovative model that's being rolled out across the country by veteran parents, and folks on the panel will speak more about this, but they're also known as parent partners, family advisors, and family peer advocates. Next slide. What we do know about the impact of family support in mental health care is somewhat sparse. There's a lot more written about the provision of peer-delivered family support services in the health literature, as well as for adults with mental health difficulties. But what we know so far is encouraging. We know that it reduces stigma and distrust, and it enhances communication between providers and family members. It enhances activation in seeking care, as well as self-efficacy, so becoming an active participant in the decision-making of their care or their loved one's care. It enhances engagement in services and knowledge about mental health services, dispelling misperceptions and inaccurate beliefs about treatment and mental health. However, there's a lot that still needs to be done. There are several critical areas that we need to be pushing efforts into gaining more knowledge, and those include really what is it that family advocates or family advisors or parent partners do. So what are their specific roles, responsibilities, and practices? effectiveness studies. As of yet, we really don't have any studies that look at outcomes like costs and child and family outcomes, specifically in the child mental health literature. Intervention enhancement studies, so if you have a peer or parent partner as part of a team, does that produce any additional value versus a, say, a clinical professional working solo? Studies using peer and team-led family support and prevention programs. There's very little literature about prevention programs that involve parent partners, as well as mediator and moderator analyses to really understand what family support factors account for which outcomes.
Hi, everybody. This is Ann Cuppinger from Families Together. I just wanted to give everybody a little bit of a sense of the kind of infrastructure around family-to-family support in New York State. And for some of you, this may be something that you already know, but I think along the way it'll help us frame the rest of the conversation. So, we really think in a very cross-systems way as families, because children and families' needs don't naturally land in one system or another. And one of the great things about family support is when family support works with families, they are taking that view, and they're helping families navigate multiple systems and try to integrate and make sense of all of those different pieces that could come together to help support that family and help that family become stronger. The leadership for all of this in New York State really has come very strongly from the New York State Office of Mental Health, the Division of Children and Families. And with all of the children's systems joining through the Children's Plan to really articulate a vision for family-driven and youth-guided care. Most of what we call family support in New York State right now is funded by the New York State Office of Mental Health through some state aid dollars, sometimes through reinvestment. In some communities, there is a fair amount of Department of Social Services money and local mental health appropriations funding going into this. But the leadership so far has really come from OMH. Families Together is doing a lot of work as a statewide organization with, here in Albany, sort of at a legislative and policy level, through the chapters, which are local affiliates of Families Together. We have 10 regional parent advisors. There are 2 parent advisors in each of the 5 New York State Office of Mental Health regions. And those folks are really there to help infuse family voice into all of the children and family services work at a regional level and to support the growth and development of family support programs and work with families in the counties and the communities that are a part of their region. There are, in terms of family support programs, there are probably about 100 family support programs across the state. But we also have a lot of advocates that are embedded in other settings. So they're not in something that's called a family support program, but they're like Joan working with the Albany County Department of Mental Health. Or they might be embedded in a residential program or working in an inpatient facility, working in partnership with a clinic. So the beautiful thing, I think, about family support in New York State is we have all different types and flavors of family support. It makes it hard sometimes to, describe it in a way that's easy. But what I like about that is that family support has been able to grow and develop and flourish in lots of different ways in New York. There's still lots of new avenues for growth, and I think our 400 or so family advocates are very nicely kind of insinuating themselves in places where they haven't worked so much before. So we're starting to have conversations about family advocates working more on mobile crisis teams, working in psychiatric emergency rooms, working more as a part of clinic teams. I think Albany County has really led the way and is going to talk to us a little bit more about what that looks like for them. And with the 4 R's and 2 S's initiative that's a part of CTAC, I think some clinics are getting some really nice experience partnering with family advocates in their community to deliver services that use family support providers in partnership with clinicians. So here at Families Together, I head up something that's a training and credentialing initiative. And Jerry mentioned in her introduction that 10 or so years ago, people looked around and said, wow, we have these family advocates, but we don't really have a training that was specifically designed to support their role. And so a number of family advocates in New York City, along with some researchers on this phone call and clinicians also, got together and designed the Parent Empowerment Program, or PEP training. That has gone through any number of revisions over the years to try to incorporate all the new things that we're learning about what makes family advocates do their best work. And we're currently delivering that training across the state. It's a 5-day training with 6 months of consultation calls to help everybody integrate what they learn into their day-to-day practice. And we're really excited about what we're hearing from people about how that training helps family advocates really understand their role and think very strategically about how they can use their lived experience as the parent or primary caregiver of a child with behavioral health challenges, how they can use that experience to help other families move forward and feel strong and become really effective advocates for their own children. Related to that, but not exactly the same, is a conversation that evolved about the need to begin to formalize a conversation about what are the required competencies to be a really capable family advocate. And so over a number of years, that conversation played out, and it has led to the establishment of a credentialing process for family peer advocates, which is also managed out of our office. We have about 200 family advocates in New York State, and I'm going to tell you a little bit more about that as well. So when we look at, what exactly is the role of the family advocate, obviously people are settled into this work in different ways in the places in which they are working. But there are some core functions, and we really like to look at these because they form the nucleus of what is a unique profession. We need everybody. We need social workers and psychologists and teachers and all different kinds of professionals. But the family advocate is playing a very specific role. And not that some of these things don't occur as part of the job of other professionals, but the family advocate's very focused on the parent or caregiver and working to empower them, to promote resiliency, to help them learn how to navigate all these complex systems, to walk beside them while they learn to advocate for their family, to really focus on engagement. This is a really important thing for clinics, because what we've learned about family in the past, about many families and their experience with clinics, is that they haven't been completely and thoroughly engaged. And what that looks like is that people don't keep coming back. But when you have a family advocate working with clinical partners and you're thinking really actively about the family's experience of care, you can really address some of those feelings that compromise engagement and promote the kinds of activities that support really good engagement. Family advocates do a lot with families to help them gain knowledge about their child's needs and to help them develop skills, both skills to navigate the system and parenting skills and skills about how to take care of themselves. They're in this for the long haul, and family advocates do spend a great deal of time helping families learn how to take care of, sort of put your oxygen mask on the mother so that they can continue to be there for their family. The PEP training and the work that we do really looks a lot at fostering partnerships between families and clinicians. We are very clear that this isn't a conversation about that's negative, but it really is how can we support you and the clinicians that you're working with to talk with each other, to understand each other's perspective, to value each other's expertise as a real key component of getting good outcomes. The other piece that we work a lot on during the PEP training that's a part of the role of the family advocate is to use their own personal story, the elements of their journey with their own child or children through the system to help other families. And that's a very tricky thing to learn at first. It's not just about sort of retelling your entire story from A to Z, but it's about how to draw on that experience in a way that helps the family that you're working with kind of see the light at the end of the tunnel, realize that this doesn't have to be a blame game, and to inspire hope. And I know Joan and Sandra will be talking some more about that. So all of this work that we're doing is really very much in step with what we're hearing around healthcare reform. There's a lot of talk about peer services. There's a lot of discussion around engagement, the idea that services shouldn't necessarily be at a high level for always, but that we're looking at self-advocacy and resiliency, and a real commitment to cost-effectiveness. Family-to-family support is a cost-effective service, and it's flexible enough that you can increase and decrease it as families' needs change. Family advocates are also really going to be critical in these efforts to coordinate care. Any conversation you've heard about BHOs and health homes are all about care coordination. And I would hazard to guess that if there's anyone in this state who understands care coordination, it's our family peer advocates. So I talked a little bit about the PEP training, and this gives you a little bit more information that you can refer back to. I think one of the pieces that I do want to talk about is that we use a strategy in the PEP training called the Parents as Agents of Change model. And it sounds a little bit more sort of formal than it is, but what it is it's a way of thinking in a structured way with families about what is getting in the way of their taking the actions that they intend to take on behalf of their family. So one of the examples that we use is, a family wants to be more involved with their child's education, but they just can't quite bring themselves to show up at parent-teacher meetings, and they're not as active and involved as they want to be. They're not feeling like they know what to do. And so we help them kind of unpack that, and we look at some different factors in a structured way about what might be getting in the way of the family taking that action and help problem solve with the family around how to clear some of those things out of the way. And what our advocates are telling us is that it's a very, very useful tool to help not have family support be just something that is pleasant and enjoyable that you are involved in, but something that really helps you accomplish your goals and objectives as a family. Jim Rodriguez is one of our original PEP developers, and he is a mental health clinician who works in a school-based mental health program in New York City. And I think he puts it really nicely that the PEP is really about the idea that there should be equality and collaboration between family members and their providers in the delivery of service and in training. So the PEP training is co-taught by a family partner and a clinical partner. So a little bit more on the credentialing. We have, lots of reasons for doing this credentialing. I think the fundamental reason is that we want to be sure that when we say to a family, this is a family advocate, that that person is coming prepared, aware of a code of ethics, equipped with basic training, supported by good supervision, and that we can give family the assurance that this is somebody that you can trust to work with your family. That works well for providers as well. When you hire this person and you know that they're a credentialed family advocate, you know what training they've been through, you know what they've had to document in terms of their experience. So it gives us some assurance that people have those minimum competencies, and in many cases, way more than minimum competencies to perform that role. The discussion around credentialing has also helped us clarify the role of family advocates, and that's an ongoing process. It's supported by this statewide PEP training that's a common shared training. And I think what's nice about any credentialing process is that as we learn more, as the research evolves and we find out what are sort of the active ingredients that make family support a powerful service, we can adapt our training and our credentialing requirements to help move the profession along, just like any other profession where knowledge changes and people continue to learn and grow through continuing education. We're also really looking to kind of form a professional identity and a professional association, and that will continue to develop through opportunities for people to work and collaborate and continue their training. So we're at about 200 now, which we think is about half of the family peer advocates in New York State. And I have 10 or so more applications in my office, so they're coming in all the time. So I want to talk really quickly about what this might mean for those of you who are working in a clinic setting. Why should it matter to you? Why would you want to partner with a family advocate? I think, you know, to some extent I may be preaching to the choir, but you're going to hear more from some folks who are living this on a day-to-day basis. But I think that when a family comes to any kind of a provider, there sometimes is some history that may or may not have been positive. They are probably stressed. They may be skeptical about, they may just doubt the ability of the system to understand them and their family. And just, we hear from families that just the mere presence of a family member working for that clinic is like an endorsement of the clinic's intention to really work authentically with that family. It's like, oh, they hired you, rather than, you know, they have negative attitudes toward families, you know, things that might not even have been true. But this presence of the family advocate has a very powerful, makes a very powerful statement about the clinic's beliefs about families. Family advocates have proven to be very helpful with outreach and engagement. The family advocates are able to work with the family to help prioritize. You know, when a family comes in, they have 700 issues that are hot right now. But through a series of conversations and good listening, the family advocates are able to help the family say, okay, like, there are all these things, and I do need to address all these things, but the first three things I really want to tackle are these. And that can be very helpful for a clinical partner to be able to focus on, you know, what they're really going to work on first. And the family advocate can then help with care coordination, can work on helping the family develop their community and natural supports, and they can be part of that multidisciplinary clinic team and bring the family voice into the conversation, bring the community voice into the conversation. And they can also provide opportunities to help the families connect up with other families as a part of that natural support system that we want to see families developing. And with that, I'm going to hand this off to Jerry Burton.
Hi, this is Jerry. This particular slide is a pretty interesting slide. Parent partners and clinical providers, common ground, working through fear. A lot of times there may be issues between clinical providers and parent partners. And as you can see from the slide, you have working in isolation, no collaboration. You have a bunch of people on that side of the cliff trying to figure out how they're going to get to the other side where the partnership is, and in the middle is this big fear factor. However, it shouldn't be that way because we both bring, you know, specific things to the table, and the common ground should be the children and families that we are working with to help us to get to a common goal. And that can be done fairly easy. You know, if both parties come together and work together, it definitely can be a beautiful thing. I have worked with families and, you know, other clinical providers and helped them, you know, bridge that gap and get through whatever it was that they needed to get through to make sure that the common goal was met. Next slide, please. So here's some lessons that we've learned thus far. Meaningful family involvement doesn't just happen. There must be a strategy. As we know, there needs to be some engagement that needs to be done early on, and that's really, really important because, again, as Ann spoke about earlier, a lot of families may have been through the system before. There may be some beliefs, some values that they're hearing from other people that may not allow them to move forward. So you need to be able to work through those things to get to the common goal. It is always an evolution. This is a paradigm shift for parents and for professionals. Very true. A lot of times, you know, again, the fear is in the way. There's a lack of trust, and it's important to be able to get to, again, the goal. There needs to be some evolution so the shift can be made in a positive, strength-based manner. And it is definitely about relationships. No matter what anyone says, if you have some preconceived ideas about each other, it's not going to work. And you have to learn to work through those things to be able to move forward. And it needs to be safe, trusting environments need nurturing. That is so true. And again, once you can get through these things, the relationship turns out to be a very good one. I have heard parents and caregivers that I work with say that, you know, they consider their clinical provider to not only be have that type of relationship with them, but consider them to be a friend, and that's very empowering as well. It's very helpful, and it definitely helps the relationship with that clinical provider to be one that can be very positive and move forward, again, working toward the goals that the family needs to get to.
Good afternoon, Maura Manning, here with Joan Ruckert, and we're going to talk to you a little bit about what we have done here in Albany County. Really the basis of really pushing the whole family involvement movement really dated back to 2001 when our former county executive really had the vision of having an integrated children's services department. His goal was really to avoid the fragmentation of services and really have one doorway so families could access the services that they needed for their children. Therefore, our department actually includes not only child welfare, including prevention, as well as child protective services, but also the Division of Special Needs, which includes early intervention, healthy families, preschool education, as well as our children's mental health clinic. I should say mental health services, because we also have case management and our single point of access. So under this one umbrella, we're able to really work collaboratively across the systems and to really hopefully meet the needs of these cross-systems very challenged individuals. So in 2004, we were awarded a SAMHSA grant, a Substance Abuse Mental Health Service Administration grant, and I think mainly due to the collaboration not only with other agencies, but the forward thinking that the county had of having a one department for children, youth, and families. And so therefore we collaborated with Families Together, Ann is here today, our statewide organization, as well as the University of Albany, who did a longitudinal study to show the effectiveness of systems of care and to really look at the importance of family involvement and youth-guided services. A system of care, I do want to say, is, it's not a program, and I think that's one thing that people always think, oh, you're, infusing money, and what does the program look like? It is a philosophy of how the services are delivered. It really focuses on developing that network of community services and supports for youth with social, emotional, and behavioral concerns. Family, youth, and providers become partners so that child can function more appropriately in the community and to their fullest potential. Our system of care goals were to improve child and family functioning and also satisfaction with services, because historically as a county entity, some families are not happy with services, and we wanted to improve not only our image with families, but we know the outcomes are better when families really feel that their needs are improving and they're being heard. We wanted to create access to services, so we were avoiding a higher level of care, such as a hospitalization or out-of-home placements. And I think the one thing we did in the System of Care grant was to look at community-based services by developing family resource centers. So families didn't have that stigma of coming to a mental health clinic for treatment. They could go to down the street, and there was a resource center that was warm and welcoming and had parent partners running that entity. That they were welcomed, their needs were met socially, emotionally, and behaviorally. And also the parent partners were key in developing those natural community supports. The parent partners that we had were all from the communities we identified. We had an urban site, a rural site, and a suburban site. So they knew their community, and they were also very much accepted by their community. So our additional goals were really to early identification of children with social, emotional, and behavioral needs, as well as really the family engagement. And historically, and we've kept data on this as well, is that families are much more engaged, as I think Ann and other folks have said, when they're meeting a parent partner, that they are having someone that they can align with and to help them navigate through the system. because we know each system is very different with regulations and access, and those parent partners were key in helping families navigate the service delivery system. So our mission, again, I can just go through, it was to improve access to, and coordinated services, as well as the effectiveness of that service. And we really were focused on being community-based, culturally competent, family-driven, and youth-guided. And I think those are really key. And in addition, we have really infused those values into all of our county contracts. So any other folks that are on the phone that are administrators, it's important to put this same language in your contracts. What are these provider agencies going to do to engage families? Because we have found and we know that outcomes are better when families are engaged in treatment and engaged in the services and engaged in their community. So, that's an important piece, as well as also the buy-in from administration. And you really have to start from the county executive level to the legislative level, all across the board, because I think community response is always very positive. But in order to have that funding stream continue to come down, we constantly need to remind how important family support and youth-guided treatment is in order to have that money follow the services. The circles of support, this is actually what we call the wraparound. We've called it circles of support. We actually currently have all of our child welfare staff conduct family team meetings. They are very similar to a family circles of support meeting, that the child and family are present, and then whatever providers that are working with the family, or if there's a need area in one of those, so for example, the child doesn't have any recreational or vocational needs. We may invite somebody from the YMCA to come in to find out if that is something that they could offer additional services or supports to the family. So really the important key is having everyone at the table and developing a plan that is, again, going to work for the family. And the family is the one who's driving the plan, no matter what it may be. So again, it's important that they are the drivers of the treatment. And it goes along with, the children's plan as well, because there should be one plan for a family, not one plan under mental health and one plan under child welfare. We all have to be working together as a team. And I can say we have a parent partner who actually sits in the family teams and helps support that parent in that process. So again, I know a lot of the funding has come through mental health. And again, even in Albany County, we were a SAMHSA grant, so it was coming from federal money related to mental health and substance abuse. But truly, it really could be something that's used cross systems, because our children and families are cross systems.
Hi, this is Joan. I am the parent partner actually originally from the SAMHSA grant. We were the Suburban Outreach, which is now the Village of Colony Family Outreach Center. We had a mayor that was very impressed with what we had done through the SAMHSA grant and believes in helping families. And through his support, we were able to sustain ourselves at the Outreach Center. And then we were able to contract with the county to continue parent partner services because of the value that they found in them. As a result, we have a parent partner at mental health, we have one at probation, and we have one at child welfare. We have recently also added a contract, again through the county, but it's for prevention services, and we're the parent partners with Trinity Institute. So we also support the ICM and SEMs, the SPOA workers. So we're kind of integrated in everything. All of us came from the SAMHSA grant. We are all parents that have, through various different experiences, come to this. Myself, I'm also a special ed teacher, which has helped a lot with the advocacy at the school level. And I think having a parent partner at the clinic has benefited the families on a lot of different levels. We're part of the team at the clinic. We are not a parent. There's the parent partner and then there's the clinicians. We are treated as though we are part of the team. We are expected to do the trainings that the clinicians do. We sit on a lot of the, not boards, well, I guess some of them, our advisory boards, we're included in those as well. I think the other part of the importance of having someone in a clinic setting is that very often the youth goes to have their session with a clinician, but the parents need their own session. And we may not be providing the clinical kind of session that can be billed for, but it's a great support to our parents. And it also gives them the opportunity to share some things that they may not be comfortable sharing with the clinicians initially. I also participated in the 4 R's, 2 S's that we conducted last year, and that was important because it gave the parents' point of view. Very often I think a lot of our families think you may have experienced it, but you haven't experienced what I have. And I may not have, but when you tell your own story, they begin to understand that you do know what they're going through. I think the other thing that has helped as far as having parent partners, we've created partnerships with a lot of the school districts, and very often now they will contact us first, and because of contacting us and getting us involved with the families then go and seek the services that they need. So I think it's made it a more comfortable situation for families. And originally when we were under the SAMHSA grant, I think we were able to get people to the table for those family team meetings a lot easier than having just a clinician try and arrange those things. So I will now pass it off to the New York City group, I believe.
Good afternoon. This is Sandra Staggers again from ICL. I'm going to share just a couple of instances where we work with families and how does this look like when you partner with a family. Can you please change the slide? Okay, me being an advocate and as well having a child with a diagnosis of ODD, I have a unique perspective from the parent's point of view because I've been a lot of times where they are. Now, there's that situation, but I've been going through systems, feeling disrespected, feeling not heard, feeling insignificant when you talk to quote-unquote professionals, whether they are from clinicians or whether they're from outside agencies. And my job being a parent advocate is to give that parent back their voice, or just to support them to find their voice again. A lot of times parents, you know, have so many situations where they feel like they don't matter, and it could have been from whatever history they had in their own family that they grew up in, or just dealing with many different systems that labeled them and saw what was wrong instead of what was right. So what we start off as a parent advocate, we work with the family strengths. We ask the parent and the young person, what do you want? What do you want to start off with? What's your priorities? And a lot of times it may be something where me as a family advocate think they might not start from, or clinicians feel that they should start with something else. Parents who have been in and out of the child services with ACS, they have their own agenda, but it's important that the parent and that young person has a voice. And that's my role, to partner with them, to let them find out, you know, again, what is their belief system? What does it look like to be happy, to have your goals met? So as a youth advocate that we work also with, they talk to the young person and they find out their voice. Because many times, even as a family have their own different guidelines and their own different goals, parents and youth also have their own different ways of doing things. So we also bring in the youth piece. And a lot of times the clinicians come and they have us go into the sessions with them, because a lot of times, like other speakers spoke about earlier, a lot of times there's a lot of engagement that is not being done when it's the parent with the clinician alone because they have this distrust. They feel judged. They feel like they're going to be pointed, what's wrong with you, this is your fault type of a thing. So when the youth advocate or the parent advocate is in the room as a bridge, we help that family feel supported and have someone to, quote unquote, hold their hand until they feel safe enough to speak without that parent advocate being there. And families feel very powerful when they have that backing. So I'm going to speak of a family that I worked with a clinician who had trust issues and they had different things that had going on in their life where it made it hard. So I'm going to say family E, I would say, was a great aunt who was raising her nephew. And she had a lot of history with being disappointed by the men in her life and other different things. So she did not connect with the clinician at all. It was a male clinician. She had a lot of history with males in her life, disappointing her, abusing her, and what have you. So she couldn't trust this clinician. So what was good about my partnership with my clinical partner is that he was able to let her just be who she was because of the relationship that we have already being, in the agency and explaining our roles and sometimes the parent's point of view. The clinician was able to allow the parent to be somewhat dismissive and having to do their venting because they understood after we talked about what was going on, the family had their own stuff that they had to work out. And the partnership between the clinician and the family advocate is very important because the parent has to feel safe. The parent needs not to be rushed. The parent needs to not be saying, well, if you don't do this, I have to close your case. So as an advocate, I was there to hold the parent's hand. The youth advocate was there also to be there for that young person. And eventually, this parent was able to get engaged with that clinician because it wasn't forced upon her. And then her nephew, who had issues with making friends and didn't know how to engage, was able to trust because the youth advocate went to his home until he felt comfortable enough to come to the group and to go out in the community and make friends. And that was one instance where it really worked because the clinical partner and the family advocate put the parent first. Another family that I would say family R has very different challenges where there was a lot of miscommunication within the mom and the dad and the young person. They didn't hear each other. So as a family advocate, my job was just to have them sit at the table and just let them hear each other because the family had a lot of things going on and the young person felt like he didn't have a voice with mom and dad. So even though I'm a family advocate and I work for the parents, the partnership between the child and the parent was so important. So we brought in the young person who was a youth advocate to also help that young person find his voice. And the clinician also respected the process because we invested, in this family because we knew this family for so long, and they have been in and out of, therapy and different things going on, but it wasn't working the traditional way because they either had the family just in a room, the parent just in a room, or just the child in a room, and they never brought it together. So the family advocate and the youth advocate was able to just collaborate together, give them time to be able to form that relationship again so they can feel safe enough to be in a clinician's office together. And then the parent was able to say what was her frustrations. The young person was able to say what were their frustrations, and then it gave the clinician a different perspective because now he saw the whole picture instead of two different clinicians working with the same family and getting fragmented information. So the partnership between the advocates and the clinical partner, which I love that word partner because they're a partner. They're not a big piece, they're just a part of the whole situation, but the parent and the child are the most important part, that we work together to have that young person and that parent feel heard. So that parent just needed a TV, for example. They needed a television for their child, even though ACS wanted, different types of parenting classes and different types of anger management and all these different things. The child just wanted a TV so that he had something to watch when he went home. So as a parent advocate, I work with that family to give them a television because a lot of times we don't see the little things that the children need to help them. So that's our role. And when parents feel heard and when young people feel respected, they have a different respect for the system and they are able to have trust in themselves again, build, goals for themselves that actually see that it's attainable. And I hope that agencies and organizations really take heed to the partnership between the family voice and the partnership voice because it's very important. Thank you so much.
Hi, so I'm going to talk to you a little bit about funding for family support. In New York State, for much of what we think of as family support, family peer support, is coming to the Office of Mental Health through a program they call 1650. There's also reinvestment dollars. We have a lot of family support going on through the home and community-based waiver and through B2H. There are grants that have been made to residential programs that allow those programs to hire or contract with community-based family support programs to make sure that there was good family support access to families whose kids were in residential programs. As Joan and Maura mentioned, there's system of care grants that were able to sort of boost the presence of family advocates in different communities. And then some of those communities have been successful sustaining that funding through various means. Some provider agencies, clinics in particular, are able to use some agency administrative overhead funding, grants, fundraising, special project money to be able to get family support started. There is also an increasing amount of funding from the other systems through local DMH, through local social services, through probation, some funding from schools, not a lot, but some funding from schools, a lot of partnership, but not necessarily a lot of money. And in some places, the family support programs have been very, I think, assertive about trying to bring in and diversify their funding from those other sources, which has been a really good thing, and it's allowed them to really have the funding represent the actual cross-system work that they do. The kid that walks through the door is very likely involved in at least two, if not more, of these systems. As family support has been able to demonstrate, the role and the value that they play, those systems have been willing to come to the table and help contribute financially to the sustainability of those programs. There's a lot of work to be done in that area, and it really varies greatly by community. So looking at future funding opportunities, one of the things I want to point out to you is a paper that was done recently by the Center for Healthcare Strategies, and we'll make this available to you because there's no way you could read it here. But this paper, and somehow it started in the middle there, looks at Medicaid financing for family and youth peer support, and it's a scan of approaches in many different states. New York State isn't on here because outside of the waiver, New York State will be in the next version of this, but outside of the waiver, there isn't a lot of Medicaid funding going into family support. As New York State gets involved with behavioral health organizations and health homes, I think we're going to see new and expanded funding opportunities for family support. I believe that these organizations will have a very clear understanding of the power of family support and the cost effectiveness of family support. The challenge is going to be to have those conversations early about how to structure the entire children's model, but also the role that family support will play in that in a way that helps family support programs sustain. Some clinics are using administrative funds, and they're doing that because as they look at productivity and engagement as a really important piece of, sorry, the PowerPoint's bouncing around. Whoa, sorry everybody. As clinics have looked at the role family support can play, they're seeing that the cost savings or the productivity goes up with greater engagement, and that there's really some value to having, sorry everyone, the PowerPoint is really just doing its own thing here.
Hey Ann, I'm sorry, this is Kara.
Kara?
I'm sorry to interrupt you. I took the PowerPoint from you because I think it was stuck for you. We couldn't see what you were presenting.
Oh, what can you see now? Sorry, everyone.
Well, now I have the ball, so I'm looking at that handout that we're going to give everyone.
Okay. Oh, so switch to potential funding sources.
Great. Thanks. Sorry, everyone.
No problem. Oh, back up one. Okay. So we've had a few clinics that have said, wow, when we put a family advocate on site here, and they're really tasked to do outreach and engagement, we're seeing so much better attendance at clinic visits that it's essentially paying for itself. That's not to understate the challenge of doing that, but I do think that that's starting to happen in a few places. Obviously, we can do state Medicaid plan amendments. That's happened in other states. I think how to proceed with that really depends on the direction things go with the BHOs. Commercial insurance is certainly a conversation that can be had there. In the past and in other states, commercial insurance has played a role in supporting family support. EPSDT in New York, we don't really talk about EPSDT too much, but there are things that we can do to look at prevention funding for family support. Again, the increased participation of other agencies. So the kids you work with are frequently in the care of other system partners. And as you look at your data and you see, wow, we're serving a lot of kids who are also involved with probation, there may be opportunities for you to seek special funding to help underwrite the role of a family advocate, or for you to partner with a community-based family support program and direct the funding there, kind of like the arrangement between Albany County and Jones Organization to kind of co-locate family advocates working in your clinics. And again, I referenced the healthcare strategy paper. Next slide, Kara. So I guess I'll wrap up. I'm not sure who was doing this slide, but just in summary, for those of you who are on the call, I think we're really optimistic about the role that family peer advocates can play in kind of greasing the wheels of relationships that really help families experience a system of care that is integrated and really where the decisions are based on the family's culture, the family's preferences, the family's needs, while integrating into that process the really valuable expertise that clinical partners bring to the table. And I think that that's perhaps the most important message of all this, which is that if we're working together and really valuing the expertise of the youth, the expertise of the family, the expertise of the family partner, and the expertise of our clinical partners, that's a winning team, and that we're going to see some great outcomes with families. In terms of funding, because I know that that's a challenge for all of you, I would encourage you to really have some conversations in your community with your family support organization, identify some opportunities, back those up with data, and keep going to every forum you can possibly go to talk about the value of this, and to begin some conversations with the BHOs, the current ones, and who knows who the future BHOs will be and what that will look like. But you know who the key players are in your area, and really start those conversations now about how you want to see this be a funded part of the package of services that they're offering to families.
Thank you so much, Anne. Thank you, everybody, for all of your great words and your knowledge and sharing with us. I'm aware of the time. I'm sorry. I know we do have one question that was asked. Karen Whitbeck was asking if we could just get some insight really quickly, and then we'll conclude the webinar. So she was saying we've struggled with getting and keeping a parent advisor for our inpatient unit at GBHC. I'm committed to get our family support programs up and running. Our campus has a kids clinic, ADT program, and ACR respite. Any suggestions or people you can link me with? So I sent her to our resources at the end of the page, and then I also told her she could contact you guys. So that goes for anyone. You can feel free to contact. Yeah.
Karen, give me a call. This is Ann Cuppinger at Families Together, and I've got some ideas already for you.
I don't think she has your phone number, but you can email Ann, Karen, okay? She also asked, what do you see as the role of a parent advocate or youth advocate on an inpatient unit where the average length of stay is 3 to 4 weeks? Would you also be able to help her, Ann?
Yes.
Okay, so if anybody has any questions that we did not get to, Monjay says I would like to know how to go about signing up for the trainings to receive my credentials.
Email me.
Can anybody tell her really quickly?
Yes, this is Ann. If you email me, I'll send you a form that we use where you can let us know that you're interested in training. We'll let you know when the training's being held in your region. Sometimes you have to wait a little while because there's pretty high demand for the training, but we'll get you involved as soon as we can. And I'll also send you the credential application, and we can have a conversation about how that all works.
Great. Thank you, Ann. And thank you, everybody, once again. I'm sorry that we went a little bit over. Here are some resources. Here are upcoming CTAC events. May 17th, we're going to have a webinar with Dr. Adele Diamond from 12 to 1. In June, we're going to have peer partnership in adult services, July suicide prevention, and all of these are always 12 to 1. Thank you so much again for participating with us today, and please fill out our feedback form, and you can please feel free to email any of our amazing presenters today if you have any further questions or concerns that we didn't get to talk about today, okay? Have a great day, and we'll see you soon. Bye-bye.